Hi, I'm Katie Steiling. I'm a clinician scientist in the pulmonary division at the medical campus, and I oversaw the development and implementation of our multidisciplinary lung cancer screening program at the medical campus. And I'm here to talk about lung cancer and lung cancer screening. Next slide, please. So lung cancer is the leading cause of cancer-related death in the United States. It causes more deaths than breast cancer, prostate cancer, and colon cancer combined. Randomized clinical trials, including the National Lung Screening Trial, have shown that screening for lung cancer using low-dose CT scans improves lung cancer mortality by at least 20%. So based on those randomized trials, we launched our screening program at Boston Medical Center in March of 2015. And since that time have performed over 6,000 screening scans, which approximates to about 180 per month currently. The patients in our screening program are different than those included in randomized trials, which reflects the historical disparities in clinical trial recruitment. The patients in our program are older, they have more medical comorbidities, lower PAC years, and are more likely to be current smokers. Our program also has screened a much higher proportion of individuals that are Black and Hispanic compared to the National Lung Screening Trial and other RCTs. The cancer detection rate in our program is double that in randomized controlled trials, but similar to those trials, we have begun to see a stage shift where more lung cancers are detected at an earlier stage, which are in theory curable. Next slide, please. And so while most of that is good news, I do want to touch mainly on the challenges in implementing lung cancer screening and the widespread and well-documented disparities that occur at all levels of lung cancer care. So there are disparities in risk prevention. So cigarette smoking is the leading cause of lung cancer and is associated with lower income level and lower educational level. There are disparities in diagnostic evaluation, which we've shown here at Boston Medical Center, and there are lower rates of pulmonary nodule evaluation and follow-up in patients that are Black and Hispanic. There are disparities in therapy for early stage and potentially curable lung cancer, where Black men are less likely to undergo surgical intervention or full resection for an early stage lung cancer than white men. And ultimately, these disparities result in a higher lung cancer mortality in patients that are Black and of lower socioeconomic status. This has been further shown by a surgical resident at BMC, Michael Poulsen, who has pulled data from the SEER database in the US Census and demonstrated that the degree of segregation in the neighborhoods, shown on the x-axis is the index of dissimilarity, is associated with a more advanced stage of diagnosis in patients who are Black, lower rates of surgery for localized disease, and higher mortality rates for lung cancer. And so these observations together suggest that both upstream and downstream factors contribute to health disparities in lung cancer care. Next slide, please. There are also significant disparities in implementation of lung cancer screening. So we did a retrospective study at Boston Medical Center and found that only 16% of potentially eligible patients actually underwent lung cancer screening. Lower screening rates were associated with older age, African American race, and lower household annual income. And together with Kay Suzuki in our thoracic surgery department, we've more recently shown that structural racism in the form of discriminatory housing practices, which is termed redlining, are associated with lower rates of screening in men and women that are Black, with a especially pronounced effect in women that are Black, and that differences in those screening rates were mitigated in non-redline neighborhoods. I want to point out a national study from the Southern Community Cohort Study in Vanderbilt that showed that the current national lung cancer screening guidelines are another source of disparities. So similar to what we've observed at our screening program here, African-American smokers had higher rates of lung cancer, lower self-reported PAC years, and were diagnosed with lung cancer at earlier ages. And importantly, a large proportion of the African-American smokers diagnosed with lung cancer would not have been eligible for lung cancer screening based on the national guidelines. Next slide, please. And so together, this sort of allows us to propose a framework to identify interventions to mitigate health inequities across the lung cancer continuum of care, which includes methods to study patient-related factors, including health beliefs, social determinants of health, and income and housing inequality, healthcare provider factors, including implicit bias and perceived discrimination, and studying methods to adjust system factors that limit access to lung cancer screening and care. And it gives us an opportunity to really impact national policy on best practices to reduce disparities in this area. Thank you.